mistakes?
First, I would like to thank the organizing committee and the organizing company and the judges, of course,
During
and
my
the
first
attendants for their kind invitation. Second, it's a pleasure to be here in Alexandria. It feels like my second hometown.
so other
residents
residents can learn how to
I am a resident at Mansoura University, and this we will go back to beginner level. This is advices from beginner resident to another beginner resident, so maybe one tip can benefit him in some case and make his beginning FACO is more easy.
These are my mistakes during my first surgeries so other residents can learn how to avoid them. The first pillar is the tunnel. In this video there is bore AC filling which will lead to long tunnel. Here there is bore fixation, bore AC formation and posterior positioning which will lead to long tunnel and conjubalonic which will make the surgery more difficult. We can overcome this by direct entry into the AC or by good viscoelastic wave and good filling of the AC. The second pillar is about capsular excess, and here are few points that should be considered. One mistake is to underfill the AC, which will lead to difficulty during rexus creation and greater risk of extension. Achieving good pupil dilatation is crucial, and in cases of narrow pupil, like in this case, we can use iris hooks. Floating and hinging in the incision is important, or you will have continuous escape of viscoelastic and bore visualization, and again, greater risk of extension. The size of the initial flap is important to determine the final size and disintegration of the rexus, like in this case, smaller initial flap led to smaller decentered rexus. Another mistake is holding at the tearing edge, not near it, which will lead to greater risk of extension and least control. It's not enough to avoid mistakes, but to know how to fix them when they happen, like in this case, enlarging the capsular rexus to get a good size. An important fix is to use Little's technique to rescue the rexus from extending to the periphery. But if the rexus is already extended and we can't retrieve it, we can create another flap from the opposite side. If we avoid the previous mistakes, rexus creation can be easier, like in this video. And the third pillar is about nucleus management. Choosing the proper plan for nucleus management is crucial. Like in this case, working without a proper plan will lead to injury to the endothelium, injury to the iris, and a greater risk for posterior capsular rupture. PCR can happen during nucleus management, like here, because of board shopping by board placing of the phaco probe near to the posterior capsule and using phaco power without engagement of any nuclear piece. PCR can also happen during epinucleus removal if you try to remove it from the center just above the posterior capsule rather than peeling it from the periphery. PCR can also happen during cortex removal, especially while removing the last piece if you use high vacuum at the periphery, like in this case. If you avoid the previous mistakes, you can do nucleus management easily. And here an example of using tilt and tumble technique, because the nucleus density in this case was not that hard. Quick tips for PCR management: early detection, stay calm, and inject viscoelastic to maintain the AC and prevent vitreous prolapse. If you avoid the previous mistakes of the main three pillars of phaco surgery, you can perform easily, even with cases with some difficulties, like in this case with paracentral corneal opacity. And finally, a quick take-home message. Always learn from your mistakes by recording your cases even in low quality. And thank you.